Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm very delighted to have you join us again. My second distinguished guest today, Dr. Ed Johnson from the Wound Care Center here in Monterey. Dr. Johnson, thanks so much for being here.
My pleasure.
Dr. Johnson, once again, we've got a Monterey High School grad, local boy makes good, back here running the Wound Care Center. I think that's so terrific. Congratulations, Dr. Johnson.
Oh, it's wonderful. It's always good to be back home. I have family and friends here, so it's a great place to practice and live.
Well, Dr. Johnson, they must be very proud of you. Monterey High grad goes off, United States Air Force, right?
Yeah, I did time in the Air Force. I'm actually still in the reserves as well. So
terrific. And so tell us about your current position now. You are staffing, you're in charge of the hyperbaric oxygen unit in the Wound Care Center. Isn't that right?
That's correct, up at the Community Hospital in the Monterey Peninsula. I've been up there about 2.5 years now. And so a service that was already in existence run through the physical therapy department, which has been handling wounds for about 15 or 20 years. So the adjunctive addition of the hyperbaric oxygen really supplemented that. And now I'm actually overseeing both of those service delivery lines. So it's going really well.
Well, Dr. Johnson, I want to talk about a little bit about your background and how the training period is to get to be a wound care doctor. And then I want to talk about something about your average week, like what's your week like. So let's go back and talk about your background. As I said, and I'm sure they're very proud of you, you're a Monterey High grad.
Sure.
So to become a wound care specialist, what's the training period like?
Like any of the other MD physicians, you complete your undergraduate training. Typically it's 4 years, and then you go on to medical school for 4 years. And then there's a number of avenues you can actually do to get into wound care, because wound care spans pretty much very many specialties, including internal medicine, surgery, family medicine. My own personal background is that I went to the University of California system for undergraduate and for medical school. And then I actually returned to Natividad Medical Center, where I did a family medicine residency, which is 3 years. And then I was very interested in obstetrics at that time, and I went to Santa Clara Valley Medical Center and did an additional year for obstetrics and family medicine. So I delivered babies for a while and did full service care for about 6 years. And then I went into the Air Force, and that's how I got exposed to hyperbaric medicine and wound care. And I went on and did an aerospace medicine residency and then a fellowship in hyperbaric medicine and wound care at the University of Pennsylvania. So
in the United States Air Force?
Actually, I had finished with the Air Force when I went back for my fellowship. My aerospace medicine residency was during my time in the Air Force.
I see. Now, were you on active duty in the Air Force? For how long?
8 years.
Terrific, Dr. Johnson. And now, did you say that you're in active reserve or you're active reserve?
Active reserves.
Still in the Air Force?
Yes, Colonel.
That's a Colonel?
Yes. Don't salute, though.
Wow. I don't know if I should call you doctor or colonel. I mean, it's both honorable. Okay, Dr. Johnson, so let's talk a little bit about your average day, your average week as a wound care specialist and running the Hyperbaric Oxygen Center here in Monterey.
Okay, very good. We have 2 hyperbaric chambers up at the hospital. We have a capacity to run them simultaneously, and we can treat about 8 patients per day in the chambers. At the same time, I have a wound care center that's situated directly with me in that same section, where I'm able to see wound care patients simultaneously. Just down the hall slightly is where the physical therapists are performing their wound care, and on occasion I'm able to assist them with ongoing supervision of their patients as well. And in addition, I'll do consultations for occasionally patients of yours or other surgeons or internists that have patients in-house that would like a physician to do a wound care consultation and or hyperbaric consultation for them.
Well, Dr. Johnson, again, like my last guest, I don't mind at all telling our audience that I'm lucky enough to work with you. I see a lot of problem wounds, and we get to work together, and a lot of my patients, you'll administer hyperbaric oxygen, and you do wound care consults, and you call me about problem wounds. So I appreciate very much your collaborative attitude and the way you work together with other doctors to get people's wounds healed, especially problem wounds. I think your center is a huge addition to the community. Dr. Johnson, what I would like to do is to present 3 different wound scenarios, 3 different difficult wounds. Okay. And I'd like you to talk about the 3 different approaches that you might take to helping people with difficult wounds, if that's okay.
Very good.
Okay, so let's start out with a 60-year-old woman who has diabetes and she notices on the ball of her foot there's about a 2-inch wound that's been there for a few weeks, and she's tried to take care of it herself, but to no avail. The wound seems to be getting larger, and as I said, she has diabetes. She doesn't have great sensation in her foot, and her family doctor sends her to you to see if you can help out with that diabetic foot wound. So how do you go about helping that patient to get that wound healed, if possible?
Sure, very good, David. You know, for me, the approach is very similar, even though the patients might be different. I always generally try to approach the wounds, whether or not a hyperbaric qualified or not, the same way. I try to proceed from general to specific, and what I mean by that is I try to give them a good history to find out what's going on, and then a full physical examination. And as part of the history, obviously you uncovered one of the key features is that this lady has diabetes. I'm interested in the level of care of her diabetes. What is her control level? Has she had foot wounds in the past? Does she have problems with her peripheral vascular disease, her circulation in that leg? Has she had a bypass in that leg before? You also touched on her sensation. I'm very interested about her sensation. How did she develop this wound? Did she step on an object and this wound may have been there much longer than she has even realized? Does she perform daily foot care in terms of examinations of her wounds? And then what is her ambulatory status? Does she get around? Is she able to offload this foot? You know, from my family medicine perspective, what kind of help does she have in the household? Because that can dictate for me the type of treatment modalities that I might be able to deliver to her. So, but moving beyond that, and you know, also additionally, we could look at her medications. Does she take steroids? Is she immunocompromised in some other form or fashion? And all of those factors, you know, we're kind of truncating it, but all those factors would impact before I even moved on to looking at her physical examination.
Well, Dr. Johnson, those are all very insightful comments. You know, I recall as a medical student, sometimes medical students are taught that people with diabetes can't heal wounds. I mean, is that true?
No, that's completely false. Obviously, their wounds can be more difficult to heal because one of the key features of the diabetes is the end organ damage. And so we have this microvascular disease, you know, small vessel disease, which makes them much more difficult to heal, but yet they can be healed. And the same population of patients, unfortunately, have large vessel disease as well, which, you know, our vascular colleagues assist us with.
Okay, well, Dr. Johnson, you know, every one of these topics we could spend an hour on, but the reason why some diabetics get foot wounds is because, is that the microvascular changes, or because they're numb, or the sugar in their bloodstream is too high? What's the pathophysiology of that? Do we know?
I think you targeted all three of them, David, to be honest with you. The way that they have wounds oftentimes is undiscovered. They can step on a coin, a ball or something, a pin even, and it's because they lack the sensation. And usually that occurs over time, particularly in patients that have poor glycemic control. The same group of population of patients will have this, what they call microvascular disease, which is small little blood vessels that become clogged and inefficient in terms of delivering nutrients and oxygen to the feet. And then finally, like you alluded to, patients that have poor glycemic control, their ability for their white blood cells to function well, which helps clean up those foot wounds and prevent them from becoming infected, is impaired with elevated blood glucoses or elevated sugars.
Okay, I appreciate that very much. So, Dr. Johnson, so for this first patient scenario that I presented, it sounds like the number one assignment is to look at the patient's systemic control, make sure they're under good medical management, make sure their diabetes is under control, et cetera, even before you get to trying to get the wound to close. Is that true?
That's absolutely correct. And one big one that I forgot, which oftentimes lights the fire, not only for this particular patient, but other types of patients with peripheral vascular disease, if we have anybody who's smoking. So again, I know we're high on the public health issues right now, but if they could do anything other than control their sugar, please stop smoking. And if you are smoking, quit smoking.
Dr. Johnson, that's worth the price of admission alone right there. If there's anyone in our audience who's watching this program or listening to the radio, if they're diabetic and smoking, they're taking some huge risk, aren't they?
Yes.
Okay, so So let's go on to the second patient, a 16-year-old adolescent boy, while skateboarding, fell and he scraped the skin right off the kneecap, what we call the patella, or the patella, what we call the kneecap. And he's tried to take care of it himself for a few weeks, and that darn wound just won't close. So finally, his pediatrician sees the kid and sends him to you for help getting that wound closed. So how do you approach that, a skateboard injury where the skin was just kind of torn off the patella or kneecap? How are you going to
Sure.
help that kid?
Again, in brief, we'll do a little general history and physical examination, make sure that a thorough evaluation has been performed, particularly in a skateboarder, so we don't get into any problems. Make sure that there wasn't a fracture and an x-ray was taken if appropriate. That's one of the things. Sometimes we get a referral from one of our colleagues, and we assume certain things have happened, but all of us need to take the general to specific approach. So I'd make sure that everything appropriately had been done in terms of from an orthopedic end on him, because the last thing we want to do is have a wound that's present and then there's some other underlying problem. So taking that's in order, that he doesn't have he's not taking steroids for his asthma or some other problem that's going on. This is a wound that's relatively straightforward. The key things on these type of wounds, how long has it been present for?
About 6 weeks.
About 6 weeks.
By the time you see him.
Yeah, so what happens is there's a difference between acute wounds and chronic wounds. Generally, we demarcate them at about the 30-day mark. We state that it becomes a chronic wound. Wounds that are chronic generally are lazy wounds. They don't want to heal anymore. So generally what the modern day approach is, depending on the depth of the wound, is to go ahead and clean the wound bed up. And we can do that either with instruments such as a scalpel, scraping it gently. We can do a mechanical debridement where we spray saline and use a roughened gauze on that. And generally what we try to do, Dave, is to go ahead and get it bleeding, particularly along the edges, very gently. And again, obviously we use the appropriate anesthetic ahead of time. And once we get the wound turned back into what I would call more of an acute type of wound, then we're ready to move on to an appropriate type of dressing. And modern wound care involves using a moist wound environment, not one that's too wet and not one that's too dry. A 16-year-old should probably do well with what we would call a hydrocolloid type of dressing, a dressing that would keep it sealed inside but allow any ongoing debridement that needed to take place to occur, and then we would generally change that out in about 3 to 4 days.
I see. Now, Dr. Johnson, will either of those patients that I presented to you may or possibly be a candidate for hyperbaric oxygen?
The second case with the young man, I wouldn't think that he would be, principally because he probably has a very good oxygen delivery system. His vasculature system should be in order. He doesn't have diabetes. Case number one very well could be, and that's predicated principally on the depth of the wound. The depth of the wound. They call it a Wagner grade 3 or greater, and what that would be involvement of the tendon or bone,
right,
and or the presence of an abscess. And this particular woman, I would say she would probably be a very strong candidate. Before I did that, we also have an instrument in my office. We call it transcutaneous oximetry measurement. So it allows us to place electrodes similar to like an EKG very close to the wound, and we can actually measure their tissue oxygenation on room air like we're breathing right now with 21% oxygen. And then I can also give them what they call an oxygen challenge. I could put a mask on her and have her breathe 100% oxygen and see how those readings on those electrodes changed with that.
Well, Dr. Johnson, that's amazing. So can you, in summary, tell us what hyperbaric oxygen may do for a wound like that? Like, for example, how is hyperbaric oxygen going to change the milieu or the tissue surrounding the wound?
Sure, David. To try to give folks a little bit of an idea about what we're talking about, we're looking at basically an acrylic chamber. It's about 7 feet long and about 3.5 feet in diameter. And the patient slides in on a gurney, and then the chamber is sealed. And what we do is we pressurize the chamber for about an atmosphere or an atmosphere and a half additional. And that leads to about a 10 to 15 times the amount of oxygen that we're breathing right now. And the path and the physiology behind that is that you're delivering this intense concentration of oxygen. You get a reduction in tissue edema. You get stimulation of the white blood cells, so they're functioning better in terms of cleaning things up. And the most important in this type of wound is that after about 15 treatments, there's what they call the stimulation of angiogenesis, which is the development of these new small blood vessels, which delivers the oxygen, nutrients, and causes further connective tissue to be laid down and wound healing to occur.
Well, I appreciate that, Dr. Johnson. And you know, every time I go up to your unit in the hospital and I see those hyperbaric oxygen, do you call them tanks or do you call them?
Yeah, we do call them tanks, and the origin of that is through the Navy, you know, because
right. Of course. You know, it reminds me of some of those science fiction movies or Star Trek where the guys get in those not time travel, but long-term transport tubes, and they're very well taken care of.
Yes.
You know, Dr. Johnson, we've only got about a minute left, but can we briefly talk about a radiation wound and what your approach might be before we wrap up this segment?
Sure. We do. We see a fair number. Again, this is the tip of the iceberg. I think by and large, most patients with radiation treatment do well. We see the ones that, you know, are doing well because they've actually been fortunate to live longer, and which is a good thing. But essentially, the treatments, the radiation treatments damage, obviously, cancer cells, but they can damage some of the surrounding tissues as well. And not only do they damage those tissues, they damage some of the small blood vasculature around those. And what the hyperbaric oxygen does is actually stimulate, like they do in the diabetics, the development of these new small blood vessels, which allows the tissues to be fed, oxygenated, and nutrients delivered. And the good thing about that is those changes are long-lasting.
So you can actually induce new vessels to grow around a wound.
Yes, new small blood
with
vessels.
the hyperbaric oxygen.
That's correct.
That's terrific. Dr. Ed Johnson, wound care specialist, you're right here in Monterey. Quickly, do we have a phone number we can give out or a website or anything like that?
Yes, there, we can give you both. The phone number up at the unit is 625-4835.
625-4835.
Yes, and I have my own website. It's www.oxygen-doc.com.
Oxygen-doc.com.
Yes, and you can see the chambers there and get some more information about hyperbaric oxygen therapy.
Dr. Ed Johnson, Colonel Johnson, I'm so impressed. Yeah, I learned so much about my guests when you guys come on. Thanks very much for being here. I appreciate it.
Enjoyed it.
Please come again.
Very good.
I am Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to come right back after a very brief pause for a very